Okay, thank you.
Thank you.
Um, I'm just and actually see me. And if you have problems, please type out the issue and I will see what can be done. But thank you for having me. Good afternoon, everybody. Thank you in particular for having me back. For those of you who don't know me, um, my name is Dr. Jigme Sethi. Let me see if I can get this working. And as you can see, sleep medicine is something I dabble with on the side. Um, as you peruse this slide, which is intentionally blank, I realize, given that this is the second time I prepared for this talk, that the last time you may have gotten the wrong message for those of you who heard me present this last year. This talk is about sleep and attention and fatigue, and there is a section on alertness management procedures and suggestions. And many of you must have come here to try to know what you should do to stay alert during your residency when you're sleep deprived. And I will address that, and it's addressed very well in the handout that you will receive or can get from your GME office on Safer 2020. But if that's the message you get on how to maintain alertness, I failed. Because I think the only message I want you to get from this particular talk today is that sleep is mission critical. It is, you need your sleep, you need enough sleep, you need good quality sleep, and you have to defend and protect your need for sleep. And there's no ifs, ands, or buts about it. That's the message I want to give. And why? Well, it turns out sleep is incredibly important for memory. Let's say you're trying to learn a new skill. You're trying to play the trumpet or try to put in a new triple lumen catheter and learn that skill for the first time, or you're listening to me and trying to memorize something. Well, your neurons are active, pathways are being activated, and the synapses are furiously forming during that period to try to encode those memory details into your brain. And this information is first encoded in the hippocampus. And when you go to sleep at night, that night, slow wave sleep or deep sleep occurs mostly in those pathways that have been active during the day. And during that period, the short-term memories or the short-term learning that is stored in a short-term bin in the hippocampus is then transferred for long-term storage to the neocortical sites in the brain, and that's called system consolidation. If you don't sleep, that transfer does not occur. If you don't get slow wave sleep, that transfer does not occur. And the next step after that transfer has successfully occurred is that synapses are downscaled so that you can continue to accumulate new knowledge with new synapses when you wake up the next morning. After that slow wave sleep is over, REM sleep sets in. And during REM sleep, these permanent areas of the neocortex, which are storing that information or that memory, if you call it that nascent memory, for long-term retrieval, those long-term retrieval synapses are built up. And that's called synaptic consolidation. So it makes perfect sense that if you don't sleep, you won't learn. And if you do have to learn, you need to get that slow wave and then the REM sleep down the road for you to improve. Okay, so sleep is important for that reason, but it's also important for other reasons that I'll address later. So normal sleep looks like this. You start off awake, you proceed through light sleep, which is stages 1 and 2. Nowadays, stage 3 and 4 are classified as slow wave sleep, and that occurs about 30 minutes after you fall asleep. Then you progressively lighten through stages 1 and you go into your first REM sleep episode or dream episode about 90 minutes after you fall asleep. Thereafter, back down to stage 2, back to slow wave sleep, and then you awaken again. And these REM sleep episodes occur every 90 to 110 minutes, and they gradually prolong in duration over the course of the night. And you may wake up here from one REM sleep, then you'll go back to light sleep. But notice that slow wave sleep or deep sleep occurs predominantly in the early part of the night. the opposite of REM sleep, which prolongs and occurs more frequently in the latter part of the night. And if you get disturbed here, your sleep is fractionated, you wake up, then you fall back to stage 1 or 2, and then you come back to REM. And often you wake up from REM in the morning, and that's why you remember your dream when you've woken up. Contrast this with a resident sleep. You can see the amount the sleep is fractionated. You wake up, go back to sleep, wake up again, lighter sleep, maybe you're not fully awake, you go through REM, then you're awakened, you go up, and these cycles to full awakeness occur so often during the night, and this constitutes fragmented sleep. And obviously, you're not going to get the same amount of REM, you're not going to get the most important slow wave sleep, which is attenuated, as you can see here, earlier in the night. So what happens over the course of a lifespan? Well, the amount of sleep you need probably doesn't change that much. Stage 1, the lighter stages of sleep, 1 and 2, they stay around the same all the way from age 5 to age 85. What does differ though is that slow wave sleep decreases. And remember, that's important for system consolidation or the building up of memory, which is why when you get to my stage here, you can't teach an old dog new tricks, because there's not enough slow wave sleep to actually allow for new memories to be consolidated. Well, I'm exaggerating a little, but that's part of it. And the other difference that occurs is as you get older, wake after sleep onset increases. In other words, sleep tends to be a little more fractionated, but sleep latency, the total amount of sleep, the total amount of REM sleep, all of that stays approximately the same over the age group. Now, what makes us sleepy? Well, there's a process H, or homeostasis, or S, sleepiness, and this consists of the accumulation of adenosine. Now, those of you who've heard me on rounds, you know that I call ATP the molecular currency of life. And when you're awake, your brain is using ATP because that's the molecule of energy. And over time, as you use up ATP, it's degraded to adenosine. Adenosine then binds to adenosine A1 and A2A receptors. These receptors block the production of dopamine, and as a result, we become sleepy. The longer we stay awake, the more adenosine, the less dopamine, the more sleepiness. Now, when you do sleep, that adenosine is recycled back to ATP, and you're ready for an energetic next day. Now, caffeine, if you look at the structure of caffeine, it looks a lot like the side rings of adenosine. So what caffeine actually does, and why it helps keep you awake, is that it binds in place of adenosine to the receptors and prevent the receptors from inhibiting dopamine release. Therefore, the receptors, the adenosine A1 and A2A receptors, continue to produce dopamine, and you stay awake. So that's, thank God for caffeine. Well, what about what keeps you awake? Those were the processes called process H or C, H or S. What about process C? Well, process C is the circadian process, which keeps us awake during the day and asleep at night. So the suprachiasmatic nucleus has circadian oscillators. These neurons fire on a 24-hour cycle, and they are entrained by zeitgebers or time givers, which are external time cues. So when you're exposed to bright light or the light from your cell phones at night, the blue light stimulates melanopsin, and melanopsin entrains information about daytime into the circadian oscillators of the SCN. On the other hand, melatonin is produced from the pineal gland, and that negatively feeds back. The levels are suppressed in bright light, and at night, melatonin accumulates and makes you sleepy. So this is the circadian regulation of sleep. And it looks like this. Process H is the accumulation of adenosine, and that continues for as long as you're awake. Process C keeps you awake during the day, and then as the light tapers off, the melatonin increases, the light cues are reduced, and gradually the circadian rhythm switches down towards a low core body temperature and the onset of sleep. And this is where you sleep. The adenosine levels come down, so the homeostatic level drive is reduced, and you stay awake until the circadian element of your rhythm starts waking you up, and that's when you start using adenosine again, and that process continues till the next night when you fall asleep. However, think of this part between 7 and 11 o'clock or 7 and 10 in the morning. This is the part where if you have stayed up all night, think about it, your adenosine level has continued all the way up at this point, and you are now very sleepy. Your circadian drive hasn't quite woken you up that much. That'll peak around noon or 3 o'clock. And so this is the time on morning rounds when you are more likely to be sleepy because of the accumulation of adenosine and the lack of much of a circadian drive right at the time when your attending wants you to be bright and sunny. Okay. So now we get to why this talk is being given. I've been tasked with talking to you about the risk factors for sleepiness, and you've got to recognize the signs of sleepiness. I will describe the impact that it has on the three people that are most important: the resident, their family, and the patients they take care of. I'll talk about some misconceptions and dispel the myths along the way. And finally, we'll go to some of the alertness management tools and strategies for yourself. And as far as this part is concerned, your program, well, that's above my pay grade and above my IQ. That will require the dean, the program directors, and your student body representatives to sit together and see what you can do to make sleep protection and alertness management more cohesive and functional in your program. I will provide some suggestions. Okay, so what are the risk factors for being sleepy? Well, first, because you live in the United States. In 2016, the CDC issued this MMWR declaring insufficient sleep syndrome or short sleep duration to be a public health epidemic. About 1/3 of Americans don't sleep don't get their minimum duration of 7 hours of sleep. And it's most prominent in the southeastern United States and around the Appalachian Mountains, which is also the stroke and the obesity belt and the hypertension belt, and where Chattanooga is located. Now, I blame Thomas Alva Edison for inventing the light bulb, which put paid to the practice of falling asleep with sunset and waking up with sunrise. And interestingly enough, this is a guy who said that most of his days, he never slept more than 4 or 5 hours of sleep. He never needed more sleep. Yet every picture of him in posterity shows him napping, whether it's outside or in his laboratory, or he even had a bed in his library. And so be it regarding not needing a lot of sleep. Now, I think actually, I don't know if you can see his name out here, Holoniak, he invented the LED. And I think this is a problem. I know that I go to bed, and once I'm in bed, instead of sleeping, I pull out my cell phone and log on to Reddit or the web. And this is what keeps us awake way more than I think the light bulb does. So the second risk for sleepiness is the nature of your job. Obviously, your sleep is fragmented when you do manage to catch some sleep while on call because of pagers and phone calls, or in the case of myself, even when I'm not on call, there are problems to be solved and issues to be dealt with. So sleep is fragmented. Insufficient sleep because you're on call, because by the time you finish work, you go home too late, you've got other things to attend to, and of course, the all-important circadian rhythm disruption, which comes with night float and rotating shifts. And some of you may have primary sleep disorders, but I can tell you that the severity of the sleep loss and the extent of the sleepiness is pathologic in residents. It's almost to the point of narcolepsy. It's certainly more than that experienced by people with sleep apnea, and it is a disease, albeit a short-lived one if you have a 3-year residency and not 7. And that's why specialties most likely to report the experiences of sleep deprivation are the surgical specialties, of course, neurology and OBGYN and pediatrics, but medicine residents are very well rested. Not. So how much sleep do we need? The cultural norms say sleep is optional. If you're a more dedicated doctor, you don't need your sleep. But actually, if you look at this data from the American Sleep, the National Sleep Foundation, you can see that for all the adult years from 18 through to 65, the recommended amount of sleep is 7 to 9 years. And when you get to my stage where I'm ready to retire, it's probably not that much different, maybe an hour different. So the amount of sleep in adulthood is 7 to 9 hours for most people. So if you're like a lot of residents, you might say, well, you know, that's all very well and good. Sorry. That's all very well and good, but I only need 5 hours of sleep. Now, I've been told to toe the party line, which says sleep loss is cumulative. You develop a sleep debt. There's nobody who needs 5 hours of sleep, but actually it may be, what is true is vulnerability to sleep depression is heritable. So this shows you from studies in mono and dizygotic twins that sleep deprivation is a highly heritable trait in humans, and in mice too. And in mice, the locus for that trait was identified on chromosome 13. And this is from another study published a few years ago that shows that certain features of the hippocampus, which I will show you, accurately predict which individuals are either susceptible or conversely resilient to memory impairments caused by sleep deprivation. And the military is doing a lot of research into this for obvious reasons. So this is the hippocampus. And if you look at this structure in purple, this is the CA3DG area of the hippocampus. And if this is larger volume, then you're more susceptible to a decrement in learning with lack of sleep in red. Conversely, if you catch up on your sleep, you're more likely to actually be able to reverse that decrement than people with a small volume CA3DG. Similarly, if you have low, slow wave sleep in that area of the cortex of the hippocampus, well, you're more susceptible to have a negative effect on your learning abilities. But on the other hand, you catch up very fast in blue when the sleep amount increases. So it is true that some people, not many, are superhumans and may not need as much, or at least may not have the same side effects from sleep decrements. Okay, what about adaptation? Once you are sleep deprived, can you adapt to it? Well, you cannot. So look at this screen here. This is a study by Van Dongen, and what they did is they took young men and women, and they subjected them to sleep restriction for 14 days. These were people who were made to sleep only 8 hours each night. And as you can see, their performance on psychomotor vigilance testing was pretty good. They did, over the period of 14 days, tend to have more lapses, but it was nothing like those who were restricted to 6 hours of sleep, and they rapidly and progressively started doing worse over the period of 14 days as their sleep restriction continued. Now, these folks were sleeping 8 hours, these folks were sleeping 6 hours, and actually they were the same people. They were made to sleep for 8 hours, then the study was repeated when they were restricted to 6 hours, and these same individuals were then restricted to 4 hours of sleep each night, and as they progressed through the 14-day period, you can see that the PVT lapses were really significant. On the other hand, they were also subjected to 3 consecutive days of 0 sleep. And you can see their performance here deteriorated immediately. So sleep deprivation is cumulative. And if you look at this last slide here, as their sleep debt built up, their PVT lapses progressively increased. There was no adaptation. You cannot adapt to sleep deficits. although some people may be more vulnerable depending on their genetics from others. And so here is what you should remember. Cumulative wakefulness of greater than 15 hours predicts performance lapses, and that's why your on-call schedule lasts 16 hours. 7 days or 5 hours of sleep per night is the equivalent of 1 night of sleep deprivation. 14 days of 6 hours of sleep per night is the equivalent of 48 hours of total sleep deprivation. So how do we recognize sleepiness in yourself and others? You might think it's as simple as this. This cat is more sleepy than this one, and this one is wide awake. And you've been told, well, you can recognize sleepiness by falling asleep in conferences. You tend to space out, feeling like you just don't really care, much like you must be feeling right now. And I know that my 7th grade teacher was very good at throwing chalk across the room to wake me up because she could recognize that I was sleepy. But having said that, look at this graph here from that same study. Again, the same people who were first restricted to 8 hours of sleep per night, their self-reported sleepiness score was around here. When they went to a sleep restriction of 6 and 4 hours, the scores were higher by only by about half a point, and they were performing really poorly by the end of their 14 days, but they did not recognize their sleepiness in self-reported sleepiness scores, contrasted with when they were completely sleep deprived. So you misperceive your sleep deficit. These were anesthesia residents who had a polysomnography, and they underwent an MSLT, which is a mean sleep latency test. They allow you to go to sleep and see how long you take to fall asleep. And 49% of them, half the anesthesia residents, thought they were awake when actually they had fallen asleep. So your perception of sleepiness is false the more you are sleep deprived. And then there are micro sleeps. These are episodes between 5 and 15 seconds in length where sleep intrudes upon wakefulness and you don't recognize it, but you may be spacing out. 20 interns at Mass General, they had ambulatory polysomnography. They had helmets which were measuring sleep waves and the rolling eye movements of the eyes by which you can detect whether you were awake or asleep. And you can see they had attentional deficits while rounding, where they were micro sleeping at the rate of approximately 0.75 episodes per hour without realizing it. And of course, when they went onto a schedule that allowed them to be less sleepy, those attentional deficits or micro sleeps improved. So the myth is I can tell how tired I am and when I'm not functioning well. And the fact is that is false. So how do you detect sleepiness? I want you to go through this with me. So imagine a period when you're on floors or on service for about 3 months in a year or continuously. If you have daily periods of irrepressible need to sleep and your sleep time is short, less than that expected for age, and that happens most days, and you're usually awakened by an alarm clock, and on weekends and days when you're off, you sleep in much, much longer. And when you sleep in, you feel better and you don't have narcolepsy or something else. Those are the criteria to use to see if you're chronically sleep deprived. Don't rest on your gut feeling. Now, obviously, you know from what I've said thus far that learning will be impaired by sleep deprivation, but sleep deprivation impairs every domain of your life. Your own patients may become the enemy because they stand between you and sleep. And learning, actually, when you get more sleep from 4 to 8 hours, you can see that the learning ability increases, and all the factors that tell you how stressed you are decrease as you get more sleep. The stress rating, the sense of being impaired, the sense of feeling humiliated when your attending is pimping you on rounds, all those things improve when you are more rested. And your professionalism gets affected. Residents averaging less than 5 hours of sleep per night was significantly more likely to report involvement in a malpractice suit or have committed serious medical errors by an odds ratio of 1.74. Conflict with other residents, 1.86 times odds ratio. Conflicts with nursing staff, use of alcohol, use of drugs to stay awake. All the domains of professionalism get adversely affected when you're sleep deprived. And this is no secret, back in 1971, when it was permissible to throw surgical instruments at other people in the operating room, when it wasn't time to be, when political correctness was not important. This is what the investigators found among interns. They said interns may experience transient psychopathology. Boy, that's a hard term. And it was described by an intern as, I'm so tired, I forget what the name is on the chart I'm writing in. And as a result, I write progress notes in the wrong charts and try to correct myself in the morning. And clearly, if that's the case, performance and patient safety will be adversely affected. This was a study that looked at sleep deprivation and compared performance on psychomotor vigilance testing with the same subjects when they had a blood alcohol level of 5%. And as you can see, 17 to 19 hours of sleep deprivation was equivalent to a blood alcohol content of 5%, and it became 10% with longer periods of sleep deprivation. So this is serious stuff. No wonder then that errors reported increase as you sleep less. Adverse events which are not self-reported but reported by others also increase. Errors on EKG interpretation were doubled when residents were tested when they were sleep deprived post-call, with 1.8 hours of sleep on average compared to when they were rested. You get the drift. Serious medication errors were really high but improved after they had their schedules changed so that they could sleep better. And in fact, 5 times more serious diagnostic errors occurred in residents who were not well rested. And if you look at a meta-analysis of 20 studies, when people are sleep deprived as compared to non-sleep deprived or rested, the median performance is equivalent to being really far out on the tail end of the non-deprived group. So you may not realize it, but both cognitive testing and psychomotor vigilance and your reaction times are way impaired even when you're sleep deprived. And it goes on like that. 20% more errors, 14% more time to simulate a laparoscopy when you're sleep deprived. You've seen this data on EKG interpretation. Time required to place an intra-arterial line increased in the sleep deprived patient. Your history and physical was not really well done, and you didn't score well on exams when you were sleep deprived. So all that makes sense. What about personal health and safety? Well, there's a 12-fold increased risk of premature labor, not delivery, labor from sleep deprivation and fatigue in pregnant residents and house staff. Resident depression has been associated with chronic sleep deprivation, increases from 4 on admission to residency to 30% over the first year. 3/4 of residents can report burnout symptoms that are related to work hours. And I got to tell you, January through March is the quarter during which suicide is highest among residents because of the sleep deprivation that's accumulated in the first year, as well as seasonal affective disorder. But there are other problems. Sleep deprivation is associated with cardiovascular disease, shortened lifespan, decreased immunity, and particularly for women who work night shift, breast cancer. So this is a statement from the American Heart Association. Short sleep is linked to diabetes, hypertension, coronary artery disease, and stroke incident. And sleep debt can cause weight gain. Sleep loss increases leptin levels. Leptin levels suppress appetite. So when you're sleep deprived, your appetite is increased. sleep loss increases ghrelin levels. Ghrelin actually is an appetite stimulator, so you put on weight. And if you look through these studies, you may not be able to read this, but all these studies with 8 hours of time in bed or less than 8 hours of time in bed and varying degrees of sleep deprivation, energy intake was increased by 415 calories, 559, 182 calories. So basically your caloric consumption increases when you're sleep deprived. When I came to this country, I was excited to eat in McDonald's. And when I started my residency, there was a McDonald's that was open 24/7 in the hospital. And so I used to love getting to the hospital at 2 o'clock, getting to the McDonald's at 2 o'clock in the hospital when I was on call, and finding such a long line of people lined up that I would never be able to get my hamburgers. So everybody gets, when they're sleep deprived or when they work night shift, their appetite is stimulated and they tend to gain a lot of weight, almost 30 pounds. And you can see that the people who have a short sleep time or sleep for less than 6 hours in a day, they have a 20% risk of incident MI in the 7 years during which they were followed. This is 500,000 people aged 40 to 69. And when they chronically were sleep deprived or sleeping less than 6 hours a day, within 7 years, 20% increased risk of incident MI. Now, the effects of drowsy driving. Remember those micro sleeps? So a car driving 60 miles per hour will travel more than 250 feet during a 3-second micro sleep, which can last up to 15 seconds, mind you. So it's dangerous. You know that old saw, officer, the road turned and I didn't? You fall asleep for 3 seconds and it's liable to be fatal. And in fact, this is data from residents in Harvard. For each extended work shift scheduled per month, interns had an 8.8% increased monthly risk of a motor vehicle crash and a 16% motor vehicle increased risk of a motor vehicle crash on the way to or from work. So for every single extended shift per month, that was the risk increase for a motor vehicle crash. And that's a lot of patient years and interns who were studied. Take daylight savings time. You know that during spring, you spring forward, so you lose an hour of sleep. That occurs on a Sunday. Well, take the Monday before the time change, the previous Monday, and look at the accident rate after the time change. Big increase. In winter, on the other hand, in fall, when the time change goes the other way and you can gain an hour of sleep, actually there are fewer accidents on the road nationally. And this is in Canada as well. So wherever there is a daylight savings time on and off, that's where traffic accidents occur, dramatically increased or reduced depending on just 1 hour of sleep lost or gained. And this is getting to be a legal issue. In New Jersey, driving after being without sleep for 24 hours, in other words, being on call, is explicitly and legally considered reckless driving. And there are laws pending in several states to make drowsy driving a felony. And there have been high-profile cases in courts where the lawyers accuse the hospitals for fatigue-related crashes in their staff. And you can try to recognize the signs of drowsy driving, having trouble focusing on the road, keeping your eyes open, nodding, drifting from your lane. All those are important, but remember what I told you. You tend to underestimate your performance decrement when you're sleep deprived. So what should you do? Don't be turning up the radio, chewing gum, cold air, whatever. Bottom line, take an Uber. The GME will pay for a one-way free ride by Uber. I have no idea how you get back into hospital the next day, but at least you got home safe. So the stuff you've been waiting for, alertness management strategies. Well, obviously that's synonymous with Caffeine, so let's talk about caffeine. It reduces sleep deficits at a dose, it keeps you awake at a dose of 75 to 150 milligrams. The only important thing to remember is that it kicks in within 15 minutes and the half-life is 3 to 7 hours. So it is conceivable that some people may be kept awake by coffee for almost 14 hours or longer. So it can disrupt subsequent sleep. Tolerance may develop, and of course, caffeine causes diuresis, which may interfere with your sleep. So that 75 to 150 milligrams is what you get from most ways in which you drink coffee. Cold brew and pour over coffee tends to be higher, but a Keurig and a French press somewhere in that ballpark. Or for alertness management strategies, you could try to join the Air Force. Now, during Gulf War I, the B-1 bombers got airborne in Missouri. They refueled over the Atlantic and over the Arabian Sea. Then they bombed Iraq. Now they were B-1, they were stealth bombers, but it couldn't have been a cakewalk. They bombed Iraq. They came back and refueled en route over the Atlantic until they landed back in Missouri. 17 hours. Not all of it on autopilot, mind you. How did they do it? Modafinil. And I'd love to prescribe you guys modafinil, but it's a controlled substance and not authorized for resident and house staff fatigue. Or you could be a dolphin. Fish and dolphins in particular, they fall asleep by shutting down one hemisphere at a time, while the other hemisphere is awake, helping them stay asleep without being, washed all around by ocean currents. And dolphins in particular can be trained to echolocate and report the presence of targets, and they can do that for 15 days without interruption because half the brain falls asleep while the other half is working. Not quite practical. So what is practical? Avoid starting out with a sleep deficit. I can't mention that enough. We know that residents do not stick to getting enough sleep because even when there are no call rotations or the call is light, they don't sleep more than 6.5 hours a night, which is bad form. There are lots of healthy sleep habits, but the most important thing is protect your sleep time. Enlist your family and friends, shut off your phone, get into a pre-sleep routine and go to bed and wake up at about the same time most days, and recognize that your sleep needs are non-negotiable. And work on getting those 7 to 9 hours of sleep each day, and especially before you have a period of sleep loss. Now, it works to unplug your phone, wear eye shades, cooler temperatures in your room, don't go to bed hungry, get regular exercise, but not just before you get to bed. Do not use alcohol. So alcohol may get you very sleepy, but you have a mini DTs in 4 or 6 hours or 3 hours once you metabolize the alcohol. And so you actually get a period of early awakening and increased brain arousal when you've gone to bed using the benefit of alcohol. So it's a mini DTs actually. What about napping? So the 2010 GME requirements, which limited you to an 80-hour work week, all of that suggested napping. And napping does work. You can either nap before you're coming in for call in the evening, or you can nap on the job. But there's a problem with napping, and that is sleep inertia. If you're really sleepy and you fall asleep and you don't wake up quickly, you take a longer nap, you'll wake up and find yourself groggy, and it may take even 30 minutes or 45 minutes before you're back to normal, even after you wake up after a nap. That's sleep inertia, and that's important to understand. So sleep inertia occurs when you wake up from deep sleep. So let's say you nap here, and you can see that within 30 minutes or so, you enter deep sleep. If you're woken up here after you've entered deep sleep, you'll have a 30-minute or so period when you feel groggy. That's because blood flow doesn't quite start back up in the brain for that duration of time. On the other hand, if you nap for less than that, you've gotten stage 1 and stage 2 sleep for a little while. Second thing, remember I told you that you have this process C, which is the awakening process. And so around this part, 2 to 4 o'clock, is when the circadian rhythm of process C tries to keep you awake. If you are sleep deprived and your adenosine levels or the process H is peaking here, and you try to nap here, that's probably better than napping here or here, because your circadian rhythm drive may prevent you from napping for too long and you would wake up. Another way of doing it is to drink coffee just before you nap, so that the coffee will kick in about 30 minutes, and that's the time you'll wake up from your nap and you won't experience sleep inertia. But you know, napping is easier said than done. You need to be in a place where there is not a lot of disturbance, no alarms going off, no ventilators, no beeps, no pagers. You need to enlist the help of your team members to cover for you when you're napping. You've got to find a convenient place to nap. It's not always easy to put your head on a desk and nap. And finally, you've got to be able to switch off your brain to nap. And if you're worried about your patient or worried about the task you have to complete, you won't quite get to the point of napping. So I don't think this is a strategy that works as well as it's touted, and it's been removed from the 2017 GME guidelines. What about adapting to night shifts? You can't get used to it right away. Your circadian rhythms take a week to move in that direction, and then it takes almost a week to come back. It's easier to adjust going into night call than it is to adjust coming back onto days, regardless of what you might think. Recovery from on-call sleep loss takes at least 2 nights of extended sleep. And so, you know, you've got to factor these things in. And the best way to do that is to have no sleep debt going into night call. Now, how do you prepare for night call? Well, obviously, you're going to be staying awake at night. So if you're used to sleeping at night from 8 p.m. to 3 a.m., well, try to each night during your transition, sleep later and later by an hour or maybe an hour and a half each night. Don't try 2 hours, because then you won't be able to wake up the next morning, but at least push your sleep out progressively until that night when you're going into work on your new night shift, you can go to bed at 11, wake up at 6, and then nap for a couple of hours before you go in at 7 p.m. And then you move to a daytime sleep schedule. So how to survive night float? Nap before you're getting into work. You might find when you come back out in the morning, you'd like to sleep from, let's say, 8 to 12, have a bite to eat, get whatever you need to get done, your laundry, and then go back in for a 4-hour sleep before you come in at night. You know, avoid exposure to bright light, wear dark glasses on your way home, so that you're not exposed to bright sunshine when you're leaving the hospital, because that'll prevent you going to sleep, and every hour of sleep counts. Now, this is an area of some confusion, and I have my ambivalence about this, as I warned you earlier. Program level measures to reduce fatigue. What should we do as a program? Well, the first thing is, there are work hour limits for a lot of you know, time-sensitive occupations. Truckers are not allowed to drive for more than 11 hours. Pilots are not allowed to fly for more than 8 hours per 24-hour period of time. When you go across continents and intercontinental flights, there are 2 teams of pilots. One naps, the other flies, and vice versa. Nuclear power plant workers are allowed a maximum of 12 hours. Train engineers, 12 hours. Physicians in training, 16 hours. So some of this is cultural. And why do I say that? Because in Europe, there is a maximum of 48 to 56 hours per week and no more than 13 consecutive hours, which doesn't just apply to residents, it applies to physicians as well, practicing physicians. In New Zealand, there's a maximum of 72 hours weekly and 16 consecutive hours for residents who are working. So the 2010 ACGME duty hour said 80 hours, a duty hour standard said 80 hours of work week, limiting the PG1 shifts to no more than 16 hours. You saw that because performance decreases after 15.84 hours of continuous awakeness. And they had stricter guidelines for minimum time off, etc. And they said you should schedule your conferences at times where the night float can also attend early in the morning, videotape them as we're doing now so that you can watch the lectures when you're more alert and sleep and rested. You know, maybe you don't have to do as many triple lumen catheters. Maybe you can use simulations and computerized resources. Maybe surgeons can practice laparoscopy, not on a patient because they're not in the hospital as many hours in a day now. Maybe they can do it using simulators. High-risk procedures should be done by the incoming team, and attending should be present at night to provide you teaching when you're working in the hospital at night, not just during the day. Okay. But I think the most important thing is this. They don't work because even when there isn't a schedule, you've seen that residents don't get their sleep. Secondly, multiple studies have shown that focusing on duty hours alone has not resulted in improvements in either patient care or resident well-being. And it's had a negative impact on resident education. Many studies have shown that time in OR is worsened, that light gray. Patient safety is actually worsened. Education and training is worsened. And does wellness improve? A few studies, the majority say no. Does fatigue improve? A few studies, the majority say no. And this is a forest plot describing the effect of resident duty hour restrictions on patient mortality. I don't see a change. So we've done this for 25 years, well, at least the last 10 years, and it's not quite worked. And this was a slightly more recent study which said that, well, some of the residents are more rested and interns are more rested, but because they have a shorter period of time, the system still expects them to accomplish that work, and there's more work compression and more stress. Better rested, more stressed. Evidence of the effects of resident work hours. So what has changed? Well, in 2017, all that stuff about napping disappeared. And I think what's changed is the culture has changed. There is an increased culture of support. There's shared responsibility for fatigue management in the training program. Resident well-being has become important. Now the resident can talk to their supervisor and program director and say, I am sleepy with the schedule. What can I do? So instead of it being a culture where you're wimpy if you needed to sleep, now we are supporting you. That helps. But there is one great study that I want to bring to your attention. This is a study on surgeons where they used an actigram to determine where the sleep times of these orthopedic residents actually. So an actigraphy is basically like your Apple wristwatch. It measures movement. And when you're sleeping, you can see there's very little movement. As you wake up, a lot more movement over the course of the day when you're working, and back to nothing at night. So they used actigraphy to actually measure how much their residents, orthopedic residents, were sleeping. They used self-reported scales of their alertness to get the residents' point of view. And they plugged all their sleep hours into a program called the safety model, which is software used by the Department of Defense, the four armed forces or branches of the armed forces, and the Federal Railroad Association. What that does is it takes your scores, self-reported scores, it takes the amount you slept, and they can actually model and predict your fatigue. So you are functioning at 100% mental effectiveness with no, with a normal fatigue risk when the software tells you that you are in the green range. There's an increased fatigue risk when you work up to the 70% mental effectiveness level. And when you're at a high fatigue risk, this is when your mental effectiveness level is less than 70, and the software predicts this for you. So they took these orthopedic residents and they plugged this into the system, and they could tell this is black. This is where the residents were actually awake, the dark black lines. The light lines are where they were sleeping. And this is the software's prediction, which was accurate about how their performance levels deteriorated. So they went on to night float. They had Monday, Tuesday, Wednesday off. They went on to night float. Look what happened. By day 3, while they were awake, they were operating in the seriously high alcohol level range of a high fatigue risk or 70% or less mental capacity based on that software. And then they get a bit of rest. They come in here, and this is what goes on. By the 4th day, back into red territory. So this safety model is something that the military uses for high-risk soldiers to actually predict when to take them off duty. And maybe this is something that you can consider, or we can consider in our own program. But it's expensive, and it means everybody has to have an actigraphy. But now the new, all the Apple Watches are basically, they function in that role. So they can tell you when you're sleeping and when you're awake. So that part is easy. It's the software and predicting it, and then deciding as a program, what do we want to do with people who have been declared too sleepy to function on this Friday? How do I pull somebody to do that job? And there's an elephant in the room, or rather elephant on Zoom, that I want to discuss. Our job as educators is to have the residents learn, protect their sleep so that they can do so, but also our job is to prepare them for the real world. And the real world is not forgiving. There is still the culture that sleep is optional. And more importantly, that we are not paid to sleep. And I've been told that by administrators in this hospital. And I got to tell you, our doctors who work here at night, their call room has been yanked. We do not have a call room to nap in, even if it's a 30-minute nap. And tell me where an ICU doctor is going to sleep on a unit with all the alarms. So you learn this. You learn that you need to protect your sleep. Your educators and your seniors here in a program are going to have a different culture. They're going to try to protect your sleep, assist you when you're tired, give you an Uber to drive home in. But when you enter the real world, don't expect it. So to summarize, this was a statement by the American College of Surgeons. Patients have a right to expect a healthy, alert, responsible, and responsive physician. And I don't think any patient would disagree. This is a statement that I think is equally important, attributable to a different source. Providers have a right to experience a healthy, alert, well-rested, and highly functional lifestyle. How we go about it in medicine depends on you folks, the residents in this room. You all are the providers to be in the next decade and more. And what you push for and ask for is what the industry will support. Thank you. And hopefully you've got some typed in questions that I can answer.
Thank you, Dr. Sethi. That was a really good lecture.
Thank you. You're welcome. Feel free to unmute yourself if you want and shout out questions if you've got some. I think we have a few minutes. Pamela, any questions for you? I guess everybody's looking like the folks on my slide.
Kim will get this uploaded as soon as she can.
Okay.
And we'll send the link to everyone. For those program directors or coordinators on the call, this is a required session for all residents and fellows every year, regardless of what level. And so if your residents or fellows weren't able to attend the Zoom session today, they can still get credit for it if they view later. And just keep track of that and send those attendance sheets to Kim, okay? Also, faculty, we strongly encourage at least the core faculty in all departments to attend this live session or view the recording at a later date.
And for those of you who might be interested, especially the educators in this group, I've got the references for and the original PDFs for all the articles that I mentioned if you want to review that material at a separate time. Happy to send it by email.
Thank you, Dr. Sethi, so much.
Welcome.
There's one question in the chat.
Yes.
How long can it take to pay off a sleep debt? If one has years of sleep debt, can it be recovered in a shorter period without one-to-one repayment?
No, you wouldn't be able to function if you had years of sleep debt. You have debt which you can accumulate over weeks, and you need to sleep in equal to the amount of the sleep debt. So if you remember that study where people were deprived to 6 hours and 4 hours of sleep for 14 days, let's say you go to 6 hours of sleep and you've got 28 hours to repair, well, you'll take about 3 days, they saw in that study, to come back 3 days of extra sleep by several hours, 4 hours or more each night. So it's not exactly a 1:1 ratio that your debt has to be repaid in the same quantity, but it's pretty close. So it takes 3 to 4 days to repay your sleep debt, depending on the amount that you have, but certainly not over years. Good question, though. Three more minutes, going once, going twice. So how many of you, well, I guess I can't see a show of hands, but how many of you feel that you're invulnerable to sleep loss? In other words, you think you're those people with the large, with the small CA3, area of the hippocampus that you don't get affected by sleep deprivation? Anyone want to unmute and answer that question? What I don't know is what the proportion of that kind of super resident is in the population.
Dr. Sethi, I'll admit that I think I'm super. But in listening to this information year after year, I know I'm not. Okay.
Yeah. Josh, do you think you are?
Hey, Dr. Sethi, this is Tina. I know I'm definitely not.
Yeah, but you know, this has to be tested with psychomotive testing, you know, because like I've told you, people are not aware of just how much their performance has decreased. So until you test them in a lab, you wouldn't know whether somebody's a super resident or not, or a, you know, invulnerable or less vulnerable to sleep deprivation. So perhaps the take-home message is, please don't answer yes. Okay, thank you, everybody. It's been a pleasure. We'll do this again next year.
Thank you so
Thank you,
much,
Dr.
Dr.
Sethi.
Sethi. Thanks, everyone, for coming.